her experience with us, Razelle.
Okay, thanks, Roy. Can everybody hear me? Yes. Yes, so I'd like to talk about some of the issues that we've heard about from the context of clinical trials and bringing it to patients. And some of this will be reiterating, perhaps a little differently, what you've heard before. First of all, we're learning, we know that cancers are difficult to treat, and we're learning more and more that agents work only in those with a sensitizing aberration, that there's a subset of patients that respond to a variety of different agents, and that molecular genomics gives us one tool to try to delineate what that subset is. We have experienced that in some cases, as Rick said, molecular matching can actually result in very high response rates, and there's been drugs approved or not approved yet that have shown this. So we're all very excited about this. The other thing that we're finding more and more is that many of the molecular aberrations do not segregate by disease. So for instance, when we looked at 1,000 patients with PIK3CA mutations, we found them in about 10% of cancers, advanced cancers, a variety of different cancers. There's, of course, more than this. And if we look at BRAF or any molecular aberration, the more we look, the more we find it doesn't really segregate by disease. So this is, in a way, almost a reclassification of cancer, rethinking the classification at least. And the other thing that has been happening that I think we need to acknowledge is really the stunning rate of progress. First human genome sequenced in the year 2000, it took many years, and now it takes about 10 days, and it costs $3 billion, and now it costs about $5,000. And this rate of progress is likely to continue, and that is some of what is making doing clinical trials and thinking about this so difficult, because if it takes years to do something, by the time you've completed it, the technology has moved on. The other thing that we're finding, especially with metastatic disease, is something that actually shocked me. But we looked at, as an example, 75 breast cancers that were metastatic using the Foundation Medicine panel in this case. And what we found was that there was no two patients that were alike in their aberrations. So I couldn't list all 75 on this slide, but I'll promise you that there was no. So we're calling no two patients that had the same set of molecular aberrations. So we're still in the mode that we try to find commonalities, you know, so about 15% had PIK3CA, and that's very nice. But the rest of the landscape for each of those patients is actually different, as in malignant snowflakes. So this really means that we have to rethink our old paradigms. And one of the ways we're doing this, and I know other people have mentioned similar ways, is using supercomputers and trying to find convergence pathways. But it turns out that it's not actually that simple. For instance, even if you converge on EGFR, by doing 3D crystal structures, we can find that you need a reversible inhibitor or an irreversible inhibitor, or maybe an antibody, depending on how a specific mutation changes things. And we have to remember, we're just at the tip of the iceberg. We're just doing genomics. We haven't done transcriptomics, proteomics, epigenomics. So we don't exactly know how all of this is going to integrate. Is it going to be that every patient really is an individual, or are we going to have a set number of pathways? I actually think we may have a set number of pathways, but it may number in the thousands. The other thing I want us to think about is how can we transform outcomes in solid tumors? And there's a lesson from chronic myelogenous leukemia that I want to point out, because people have talked about metastatic disease, as I have, and they've talked about prevention. But I think there's a different sweet spot that we have not addressed. CML was transformed. In the 1980s, everybody died in 4 to 6 years. Today, median survivals are probably more than 20 years. We often say that solid tumors are different, and I've seen this picture put up, a New England Journal article. Patient got a matched therapy, did great, and then got worse again. And we say, well, you know, solid tumors are different than CML. But is that really true? What we're comparing is metastatic tumors, solid tumors, to newly diagnosed CML, when in fact metastatic solid tumors should be compared to blast crisis in CML. And so what happened to transform CML? We had a known driver, we found the targeted agent, but most importantly, we moved the treatment to newly diagnosed disease, because in blast crisis CML, the response rates are about 10%. 80%. And even in 2013, patients usually don't live more than a year. So I think we really need to think about moving our therapies earlier. Evolution of clinical trial design. We thought of lung cancer as one disease. Now we know it's multiple subset of disease. Evolution number 2 is that we find that the molecular hubs are present in multiple different diseases, regardless of origin. So can we begin thinking more and more about bucket trials? And instead of doing large randomized trials where only a few patients respond, doing small trials very targeted where we expect most patients to respond. But I think that's just step 1 in the evolution. And in essence, genomics is a disruptive technology because it's really unveiling a new reality for us to cancer. And I'm not sure we're going to be able to retrofit it to old paradigms. So if each patient needs a specifically tailored treatment, and let's say there are 300 drugs in oncology, I think there's about 150 approved drugs and maybe 150, we'll say, in advanced development. There's much more in development. 2 drug combinations are 45,000. 3 drug combinations are almost 4.5 million. It would probably take over 1,000 years, maybe a lot more, to figure this out. So what do we do about that? Maybe we need to begin thinking differently. So what I'd like to propose is that we need multiplex markers to diagnose and classify cancers. This is a diagnostic test. The way we have used histology in the past, this with histology, I believe, will be the diagnostic test of the future. And maybe we need to validate a strategy, not just a drug or marker. In other words, in the past, we've validated a drug, and we don't expect everybody to respond to a drug. In fact, 80%, sometimes more patients don't. If we validate a strategy of molecular matching, can we insert new drugs in that strategy without testing every individual drug? We should understand convergence pathways. And can we use rule of thumb for safe combinations? We already do that. When a patient comes in and is put on an anti-neoplastic agent, they already may be on anti-diabetic and an antidepressant, and some of them are on 15 drugs. And we have some rules of thumbs for safe combinations. And finally, doing proof of principle trials in metastatic disease and then treating earlier. So what are some of our barriers? Most important barriers that I would like to see addressed from the clinical standpoint, making this real for patients. How do we get the drugs? We need to repurpose FDA-approved drugs. We need to get experimental drugs. This is an absolute barrier for many patients. Number 2 is what we found is we have an increased regulatory burden for molecular trials. It's easier to just select by histology. And I think maybe we need to think of lightening that or reversing that trend. And we need new clinical trial paradigms. People have mentioned N of 1 strategies, trials earlier in the course of the disease, maybe not at the prevention stage yet, but how about newly diagnosed disease or window trials, and customized combinations, an approach to customized combinations that is rationally driven. Okay, thank you. And if there's any questions, I'll address them.
Thanks, Razelle. That was wonderful. Do we have any questions now? Looks like people are holding them all for the end, which I'll encourage you to do. We're moving now from the NCI through the FDA, through a large academic center, and now to industry, the home of many drugs. And we have 2 representatives. The first is Dr. Mace Rothenberg. Mace is the Senior Vice President of Clinical Development and Medical Affairs for the Oncology Business Unit at Pfizer. Of course, prior to going to Pfizer in 2008, he spent more than 20 years in academia, including much of that at Vanderbilt University. So Mace, we'd love to hear your perspectives.
Okay.